so we're past this now. Okay, so we kind of started talking about this on Wednesday when we were talking about different ways to assess learning disorders. And we talked about intelligence and how there have been differences in the way that we measure intelligence, and then how that is related to learning disorders. We need to be able to rule out an extreme intellectual disability versus a learning disorder if we're going to diagnose it. So we started talking about intelligence, but we're primarily going to talk about it here in this section. So in terms of measuring intelligence and the terminology, there have been different terms for many, many years to describe deficits in intelligence or some sort of, like lower processing or lower level than what the norm is. So there are different terms. Here are some of those terms, and a lot of times they tend to have negative connotation as we drop certain words so that they're no longer in our vocabulary when it comes to diagnostic conversation. So because colloquially it has changed, and in the DSM or the way that we're measuring things, whether it's medical community or psychological community, the terms have changed. And so with that, the DSM-4, so prior to 2013, the last version of the DSM had this section, and now we are DSM-5, intellectual disability. So that is a terminology that was used back then. Now we are using intellectual disability. So DSM-4 and DSM-5 differ in the way that they conceptualize IQ and where intellectual disability falls when it comes to IQ. So the DSM-4, at their point, when they talked about intellectual disability and IQ, they talked about intellectual disability that includes a specific minimum IQ scores in order to get a diagnosis. So that's that 2 standard deviations thing that I was talking about on Wednesday. So you must fall 2 standard deviations below the average or the norm of IQ functioning. So in this graph, if we look at a normal distribution, the normal distribution is going to be like that 85 to 115. So 100 is the mean. That's what we expect the norm to be for most people in the public or in the community. And we're going to have standard deviations, which is here 15 and 15. 15 to the left, which takes us to 85, 15 to the right, which takes us to 115. That tells us that anyone in this section between 85 to 115 is still functioning in the average range, because we're accounting for standard deviation to the left and standard deviation to the right. However, falling 2 standard deviations below, so now we're at 70. Before, 85 was bordering on some intellectual, like we consider it like low or like low average or below average functioning. Even though that's considered that, we're right on the cusp, and we can really say that they might fall in between this normative range. So even though that's kind of a little bit getting close to the range, 70, which is 2 standard deviations below, is where we're really seeing some sort of intellectual impairment. So if you're at 70 or below, you're now at the tail ends of the normal distribution. So the majority of people do not fall in these tails. And it works both ways when we look at just statistically the normal distribution. Falling in this 130 and 145 is also abnormal when it comes to like the statistical sense. And we talked about that early on in week 1 when we talked about like what's abnormal, what are the phrases of abnormal that we're going to adopt in psychology. Part of it can be statistical, and it is the case in this original conceptualization of intellectual disability. Statistically, you are out of the norm in terms of lower intelligence. And it's not intelligence either, like you are smart or you're dumb. It's not saying that. It's this general intellectual ability, and it includes different skills like processing speed, perceptual reasoning, things like that. So it's like an aggregate of those sort of skills. So 2 standard deviation below with a standard score of 70 or less, that's what we used to say was intellectual disability. And you needed to see impairment in general mental abilities. So just in general, do you see deficits across different settings that are impacting the person? So that's DSM-4. We're now at DSM-5. So from 2013 and onwards to the present, we've abandoned the specific IQ score requirement, but we have retained general recommendations of 2 standard deviations below the mean. So we still use this, and this is what I said on Wednesday. We're not so beholden to like that IQ level cutoff, but we still assess for it because that helps us interpret what we're seeing in real life. So we see a lot of the characteristics that in DSM-4 would have been cause for intellectual testing. So we still do the assessment because, again, that's still an indication that there's something happening that is below the norm. And so having an assessment of intelligence is really helpful just as one data point. And in addition to that data point, we're also going to look at adaptive functioning. And so that's what the DSM-5 brings in, is not that you completely drop the 2 standard deviation below the mean recommendation. We're still going to incorporate that, but it's really that I'm looking at adaptive functioning. How well can you as the person independently perform common skills and tasks? So things like daily living skills. Can you brush your teeth? Are you able to put your pants on? Can you button the buttons on your pants, on your shirt, your flannel, whatever it is? Can you go to the restroom? Do you know how to tear off a piece of toilet paper and wipe yourself? Right. So those are the things that we mean by daily living. Communication is, are you verbal or nonverbal? Although you are verbal, can you speak in sequences? Can you say certain sentences? So some of the stuff we talked about with expressive and receptive language earlier in the week. And then socialization. So are there deficits in the peer communication or communication with siblings, things like that? So if these are things that we're seeing also are significantly lower and we're seeing less adaptive functioning and it's really interfering with the person's life, coupled with IQ that is 2 standard deviations below the mean, that's a pretty good indicator to us that this is some sort of intellectual disability potentially happening. So in terms of intelligence, and I said that I think once before already, it's not about like how smart you are, how well you're going to do at school. So academic achievement, we say that that's separate from intelligence. And intelligence, it's really like a catch-all phrase for different aspects of functioning or the brain functioning that we think about. So again, things like visuospatial speed, perceptual reasoning, processing speed, different things like that. So there's no one definition for intelligence, and a lot of the definitions out there are based on different theoretical orientations. And so because of that, we have no real one definition. There's not a precise nature of intelligence, but the traditional psychometric approach, psychometric is all about measurement, testing, things like that. So they looked at the products of intellectual or cognitive abilities, and it yields a general G ability and specific ability scores. So this is what I generally am talking about when I say it's processing speed, visual spatial reasoning, perceptual reasoning. Those are different subtests from an intelligence test like the WAIS, which is what I showed you last week or on Wednesday, the Wechsler, different Wechsler exams. So we saw that there were different subtests that you can get a score for. That would mean specific abilities that you're getting scores for. And then we had a full scale IQ, which is a sub of all of those subtests. And then you compare it to the norm given that child's age and sex. That will yield a final full scale IQ, which we think of as the general ability. So we look at both things. You might see, and I think there's not a ton of research, but research is starting to show, and I think clinically, a lot of people who work in this area, especially in private practice, I think like see anecdotally differences in the subtests where there's a scatter. And so you might have really, really, really high processing speed, and there's a pretty big discrepancy between your processing speed and your verbal comprehension. And what that might look like in terms of presentation is you're smart in the academic sense. Like I can see that you can solve math problems really fast when I give you this one intelligence test. But when I do the subtest of here's a word, tell me the definition in like 90 seconds, and you can't do that, or the level of ability is pretty discrepant from the child's age and sex, that tells me there's a discrepancy in 2 different subtests. And that discrepancy is used a lot clinically when we say Yeah, so that scatter might indicate some sort of neurodevelopmental difference. And so the full scale still might be in the average range, but we can see why we're seeing some struggle maybe in school when we see a difference in those two subtests. So there's not like a hard science to that. I think I've just heard, for me, anecdotally, I've heard from supervisors who've done this for many years that scatter when they give an IQ test, even though they see a full scale IQ that's in the normative range, it's in the normal bell curve. You can see how it causes impairment, especially at school. So that's in the psychometric sense. We assess everything, we compare specific abilities, and we look at the general ability. That's a traditional approach. There's also an information processing approach, and this is looking at the processes that are involved in abilities. So what's the process by which we perceive sensory stimuli, store information, manipulate information? To me, this is more of like a computer processing idea. It's like, what is the process? And we're going to measure how well you perform on these processing tasks. So there's no one right or wrong approach. I just think that this is in clinical psychology a lot, especially talking to neuropsychologists, people who are heavily based in evidence-based approaches, looking at psychometrics. I think the field in general tends to use this one traditional approach. Um, Here are some measures relevant to tests of intelligence. So what's the difference between chronological age versus mental age? What's the IQ ratio versus the IQ deviation? So I don't use this in clinical practice that much. I think when we're talking about like norms, we do have to use chronological age. When I'm thinking of the mental age, though, this is something that I might be considering not from a neuropsych perspective, but if I'm working with the kid clinically, even though they present as, or even though their age is like 11 years old, they might present as 7 years old. So to me, I'm thinking about the mental age clinically. So given all of that, we have different approaches to how we conceptualize intelligence. We have different ways of diagnosing intellectual disability. There's been a change from this hard and fast rule of 2 standard deviations to now a recommendation of 2 standard deviations plus an assessment of adaptive functioning. So we've talked a lot about like intelligence is still really important and the testing of it. So using different assessment measures is also still very common and like very lucrative in terms of a neuropsychologist workload. And so all that to say, we care about intelligence still, and there are different tests or assessments that we can give to assess intellectual ability. And the reason that we even assess it is because we think that there is stability. IQ scores are generally relatively stable. It's why when you take an IQ test when you were 7 years old, when you were referred for treatment, it's not going to change that much because you are already standardized compared to your peers. So your age and sex is compared to what your performance is. And so even though you perform at an average range in childhood and you take it again when you're 17, 10 years later, and now the norms have changed because you're comparing your score to older kids, it's not going to change that much. It's not going to take you from within the normal distribution of the bell curve to suddenly all the way down to extremely low functioning unless there's something that has happened, like a TBI or something. So in general, your score, there's not really a way to change your IQ score, like to study or something like that. If you're studying, visual spatial speed is not going to jump you up like 1 or 2 standard deviations. So in general, we think IQ scores are relatively stable. So when you're diagnosed with an intellectual disability quite young, you'll need some additional assistance as you grow up because of this IQ stability. Um, I'm not going to talk a lot about validity, just we've talked about psychometric properties. We care that tests are reliable and valid. The IQ scores or the IQ tests do have validity, but again, there's always some question of, is it culturally acceptable? Um, can people of different cultures understand your test? Is there a cultural bias? Are we scoring people lower inherently just because they speak a different language or something like that? So there's always going to be questions about the validity of these tests, and yet we still use it as an important tool. We just have to keep these caveats in mind. So with that, we think about IQ, we keep the caveats in mind, we care a lot about adaptive functioning. So We're concerned with failure to adapt to socially acceptable, well, to failure to adapt socially to one's environment. So I gave examples of like brushing your teeth, putting on your shirt, buttoning the buttons. Those are all examples of things that people do to take care of themselves. You need to have that skill in order to live independently. Having that skill at 6 years old, where you know how to do all those things, and maybe you're better at it, maybe you're more thorough now as a 17-year-old, really matters, and it's going to matter across time. It's really hard to live off on your own at 27 years old without having any of these adaptive behaviors down pat. And so there are conceptual, social, and practical adaptive behavior skills that we are concerned with when we're looking at intellectual disability. And always developmental level must be taken into account. So how does functioning, what does it look like for this particular age and developmental age range in one particular domain? So socially, am I expecting something that's out of the norm, or is it pretty reasonable given the child's age? So we're looking at both conceptual, social, and practical. Um, there are different levels of severity. This is from your book. I don't think this is like really used out like in terms of clinical work. In terms of assessment, when you give a diagnosis of intellectual disability, you can specify the severity of it. So you can say mild, moderate, and I think severe. And when you're giving those specifiers, you're basically saying like this is what I'm seeing in terms of the severity of adaptive functioning. We are really struggling in conceptual or social or practical. So it goes up in intensity given the qualifier that you're giving it. You can look at that on your own time. So it goes from mild, moderate, severe to profound. And then here's the diagnostic criteria. So what I just showed you, severe, moderate, or profound, severe, moderate, and mild, all of that is reflected in the specific severity that you can add as a specifier if you're going to give an IDD diagnosis. The specific criteria that must be met is deficits in intellectual functioning. And here it says it needs to be confirmed by both clinical assessment and individualized standard intelligence testing. So again, it just means that we need to have some sort of assessment battery to corroborate what we're seeing in terms of intellectual functioning. And then deficits in adaptive functioning, we've talked about that, and during the developmental period. So that's why it's a neurodevelopmental disorder. It's going to have some sort of onset in this early developmental period. Yeah, I like this. This is better, in my opinion, than this. This is just some examples of severity, like what does it look like across each range? And then this bubble is how do we classify people in the DSM? So this is what I'm going to use in this purple text box over here on the right when I'm actually giving a specifier of mild, moderate, severe. These are the things that I'm thinking of. Realistically, does this person require 24-hour care? Yes. Okay. And all my testing and all my clinical interviews suggest intellectual disability. Okay. Okay. So I'm going to give IDD and I'm going to give a specifier of profound severity. Again, we care more about adaptive functioning. So before the DSM-5, the specifiers were based on IQ scores, just like the actual diagnosis. And now with DSM-5 and onwards, we assign the level of severity based on adaptive functioning. So just as we would for the actual diagnosis. Okay. Any questions before I go to etiology? Etiology is like, what are some of the diagnostic, like, starting points? Okay. So there are many different causes and correlates of intellectual disability. We know some, we don't know all. But usually when you trace it back, like we look at the full history, we look at some of the genetic risk factors within the family. We might even do some genetic testing with that particular client. A lot of times we see some sort of abnormal brain development or some sort of brain injury that resulted from genetic and or environmental causes. So things like Down syndrome, right? Having an extra copy of your chromosome 21, that's over here in the image. Fragile X syndrome, Tay-Sachs disease, which is a recessive genetic condition. And so you don't have a particular enzyme that you need to have for functioning. PKU, which is another recessive genetic condition, and it leads up to having excessive amino acid phenylalanine, and then Prader-Willi syndrome, which is where your chromosome 15 is deleted from your sequence. So a lot of different genetic risk factors. So these are genetic like explanations for having intellectual disability. That's often what we see in like medical complex communities. There's this example of the Fragile X syndrome. Are you all familiar like with all of these different types of conditions? If no, I'm going to play the Prader-Willi video. Okay.
No.
Oh, yeah. Okay. Let's click this one. And of course it doesn't work. Okay, hold on. I will play the Prader-Willi. I think there's just so many genetic risk factors out there. And we think a lot about like, we'll talk about it on the next slide with environment. We talk a lot about like prenatal care and making sure like, fetal alcohol syndrome is associated with drinking, right? And when you're pregnant. And so we talk a lot about a preventative care. So I think we hear a lot about it when you're getting pregnant, or we hear about what do doctors see in a hospital when they have people come in with intellectual disability. It usually is some sort of genetic cause. For our purposes, I think it's important to know that these are some pretty common causes of intellectual disability. And here's an example. So we'll just watch what someone looks like with Prader-Willi syndrome. I think the way she talks is a little bit different. So let me just put it in YouTube. Okay.
Prader-Willi syndrome, or
Share again. Okay.
or PWS, is a rare genetic disorder that causes low muscle tone, short stature, and a chronic feeling of hunger. PWS is one of the most common conditions seen in genetics clinics and is the most common genetic cause of obesity that has been identified. There is no cure, but as Christine Rogers reports, researchers at UNC Chapel Hill are searching for answers.
Good job, good job. What about your room? We're going to put them in the big trash can in here.
Marquita Tucker is doing what she does most afternoons after school, household chores. On this day, she has garbage duty.
Good job. Now, which trash can do you put it in? Which color is it? The brown one. Good job.
Marquita gets guidance from her medical assistant, Charlene Davis. Charlene is part of the Community Alternative Program known as CAF. Her goal is to keep Marquita focused and on task.
Strong girls. That's what makes us strong in the middle. And we like to do different stuff, but we stay in the routine. The same routine every day. We stay on schedule. You on top of your game, ain't you? Getting up in the morning, a certain thing, we have to stay on schedule because everything has to fall into play along with her medication.
Marquita has Prader-Willi syndrome. It's a condition that typically causes low muscle tone, short stature, cognitive disabilities, and a chronic feeling of hunger.
Marquita got a big heart.
While her medication helps Marquita deal with some of her behavioral issues, there is nothing she can take that can satisfy her insatiable appetite.
Do you feel hungry? Is that what Prader-Willi? Sometimes you feel hungry? Or
Yeah.
You can explain to me.
Always feel hungry.
You do?
Mm-hmm.
So what do you do? How do you control that?
I move away from the food.
Is that hard sometimes?
Yes, it's very hard. It's very hard.
The refrigerator is right here.
Marquita's hunger cravings are so intense, her mother must lock the door leading to the kitchen. All of the cabinets are also locked.
This key is always on me, and if I happen to take it off, I have to hide it. She would come at night, and I could feel her. So, Marquita, is that you? Yes, Mommy. Why are you up? I don't know. Go back to bed. And that's all it takes, just send her back to bed. But if she ever gets this key off, she's headed for that kitchen.
Often around age 3, they develop a tremendous appetite. And their access to food has to be restricted or they'll gain a tremendous amount of weight. And that's really the major medical problems that we see in older children and adults with Prader-Willi syndrome is from their obesity.
When Marquita was born, her parents
Okay. So I think I was thinking of a different video with some other speech, noticeable speech differences. This is different. This is Prader-Willi, which is linked more to obesity. I think this is a good example of like functionally what is a consequence. It's not that you're necessarily going to see the exact same presentation with someone with Down syndrome versus Prader-Willi versus one of the others in terms of intellectual functioning. So I think it's a good example of she's verbal, she speaks, it's really linked to obesity. And if we were to give her an intelligence test, like the WAIS or the WISC, we would probably see standard deviation below, 2 standard deviations below the norm. So you can watch the rest of it. I think I have like 1 or 2 questions on the exam on Prader-Willi and one of these other genetic conditions. I'm not testing you on like all of them. Okay, here's the environmental side. So we talked about genetic side, here's environmental. So birth complications, fetal alcohol spectrum disorders, all of these tend to have some sort of risk associated with prenatal care or behaviors on the maternal side that happen when the child's in utero. So things just like having birth complications, so during pregnancy, losing air, hypoxia, fetal alcohol syndrome. So being exposed to alcohol in utero. So it's one of the most commonly preventable conditions out there because of its association with maternal drinking. Exposure to toxic substances such as lead, mercury, arsenic. So the WHO has this estimate out there of what are the rates of intellectual disability given lead exposure in their areas. So this little map on the right-hand side shows you, it's from the WHO, different ranges per 1,000 people, those with fetal alcohol spectrum disorder. And it looks like the ones with the highest, like so that darkest color, which is associated with some sort of toxic substance, really falls at this tip down here of Africa. And then the little boot over here and some of this region up here. So just geographically, there are differences based on exposure in the environment, which I think is pretty interesting. It says here, less than half of countries worldwide have legally banned lead paint, which is also associated with this higher prevalence of FASD in certain regions of the continents, different continents. The other thing that is thought to be associated with intellectual disability in terms of afterbirth, that's not related to the like physical environment, is inadequate intellectual stimulation. It's not the cause of intellectual disability. It's something that can maintain some of the low functioning. So not engaging with your baby or like your little toddler with activities that are intellectual stimulating is only going to maintain the low functioning. Okay, just some tables looking at the different risks based on the timing of the birth. So is it prenatal, perinatal, or is it postnatal? What are some of the risk factors within the biomedical domain, social, behavioral, and educational domain? So that's just putting together the different risks and etiological factors we talked about in the 2 slides, putting it into the context of what period is the child in, whether it's, again, prior to birth, during birth, or postnatal. In terms of prevalence rates, so it's fallen, which is good. Again, this is according to your textbook, but down from 3 to 1%. But keeping in mind that prevalence rates are shifting all the time, and there's a lot of different reasons, whether it's terminology that we're using that's differently. So one study assesses this one thing with this one term, another study assesses this. So you're going to have differences in rates. And just like a lot of other disorders, the diagnostic criteria has shifted. So if we had this hard and fast rule of 2 standard deviations as being the prerequisite to be able to give a diagnosis, that might might be inflating the number versus with a newer approach, we still are using intelligence tests. We still need to have some sort of corroboration, but we're looking a lot more now at adaptive functioning. So a difference in how we're diagnosing, a difference in how we're parsing together, is it this or is it this? All of those things are going to lead to higher or lower prevalence rates. And same thing with intervention, having an aid. So when we saw the Prader-Willi syndrome video, there was a medical aid to help assist with intervention of the day-to-day activities. So that helps. As per usual, we tend to see higher rates among males than females. And in particular, what genetic condition do we see higher rates for? Things like Fragile X syndrome. So a lot of the genetic risk factors tend to be higher. And then also, same with SES, we tend to see lower SES being associated with higher risk. Developmental course, so what does it look like over time? Intellectual disability is lifelong. So we think of autism as also being lifelong. It's a condition that's chronic, but it's manageable. You can have intervention. You mature over time. So it can look in terms of presentation and your functioning different across time, but it is a chronic condition. It's lifelong. And whether or not the outcome becomes worse or how long it is, like for how long it'll look like this for a certain period, is going to be associated with the severity of this disorder and the cause. So having, for instance, like Down syndrome, it's going to look very different than another condition that maybe is associated with intellectual disability. Sequence also matters. So children with intellectual disability typically do progress the same through the Piaget. So if we think of Piaget and the childhood steps that we expect them to go through, so all the different tasks that we expect kids to be able to develop the course of, so things like object permanence, all that stuff, like those things still occur over time, right? We're not saying that some kids are maybe not able to develop as quickly, but they still go through these steps. So the problem is that it's not on par with their age and with their peers, which is why we see that intellectual disability, but it's not to say they cannot or they do not go through these same normative progressive steps. It just looks pretty different. Okay, so all that to say, I was gonna briefly just talk about a case that I had, and then I can let you guys go early. But before I just talk about a case, any questions about this? Keeping in mind, we'll talk about autism next week. Questions? Okay. So given that these are all neurodevelopmental disorders, and we see just how many of the other associated, like the other disorders are related to another, anything under the neurodevelopmental disorders really has high comorbidity with one another. And so again, I've talked about this, neurodevelopmental disorders tends to not be within my area of clinical expertise or interest, to be honest. A lot of my research is not in this area. And so I don't have as many like recent case studies, but I'm thinking about a case that I did pre-grad school, so doing ABA. I remember I did have a client with intellectual disability that I worked with, and it was really interesting how this differs from a case that I had seen in grad school. It was not my own case, and it was something it's like across the developmental lifespan. So I was saying pre-grad school in an ABA, like autism specific context, a 22-year-old with intellectual disability and was nonverbal. And that was really different. The services, the things that she qualified for, the intervention that we did was very different for her versus one of the private practices I've worked at. They do assessments for disability determination services. So if you have an intellectual disability, if there's severe mental illness like schizophrenia, things like that, the psychologist is a forensic psychologist. He would do all of these assessments, and a lot of times we saw people with intellectual disability, but the range is, of course, across the board, like very dimensional. So I think just clinically looking at the difference, here's someone who has a caretaker but can speak to their own experience. versus this other person that I worked with many years ago who's nonverbal, cannot speak to her experiences. We were working on a lot of adaptive functioning skills. So literally going to the bathroom, like, did you wash your hands? How do we wash our hands? Oh, having like a little visual chart for washing our hands. What do you do when you're on your menstrual cycle? Things like that. So a lot of that stuff was adaptive work that we're working on, versus what this other person in adulthood was looking for, which was more like financial services to be able to pay for all of these occupational, vocational, all the things that they needed, but like applying for funding, which was really interesting to see in a different context. So both in a psych context, but different ranges of what type of services there are out there for them. So there's things like ABA, if there's like an autism related question, there's things like disability services and testing that's involved in order to be eligible for those services. So that's the extent that I've worked with this population. I'll have way more case examples when we get to all the mood, depression, personality, PTSD, all that stuff. Okay, that's all I had. Any final questions or thoughts before we end? Okay. If there's nothing, I will see you all on Monday. Just for anyone here who has been going to office hours, there's no office hour today. I will see you all Monday. Okay. All right, bye.